I would like to invite you to this wonderful journey during the tunnel time, and I would like you to jump into the balloon and to have this trip with me. The motion of the waves usually reminds me the bone tissue. Why? On one side, bone resorption, and the other side, bone apposition. We can see that osteoclasts, those cells who come from the bone marrow, usually resorb the matrix and liberate a lot of minerals and growth factors. We need those growth factors and those minerals for the hemostasis. And on the other hand, all the cells at the same time, osteoblast, bone and build a new matrix. This matrix is made of collagen and will be able to integrate those minerals for the future. This is the osteoid in which those osteoblasts are going to be osteocytes. So let's come back to the past. 76. Steve Jobs and his colleague, Steve Wozniak, in the garage of their parents, create the first Macintosh, Apple company and computer. At those time, I was a young student, and I remember the unbelievable function of the periodontal ligament fibroblasts according to the article of Anthony Melcher. 76. At this time, we knew that not every fibroblast is similar. And we knew there is a big race between all the tissue to make the healing of the bone defect. It was the first revolution. 82. The Space Shuttle Columbia has the first operational flight and will continue during 22 years to keep and to bring new information about space. This year, we heard about Jan Linde and his wonderful team in Gothenburg in Sweden, where they were working on a filter to try to give the fibroblast of the periodontal ligament to make its job. And it was the beginning of the membrane, the first millipore filter that will become the future membrane. It was in 82. We saw the guide tissue regeneration beginning, and it was the second revolution. We have done several cases in which we were able to build and to regenerate any bone defect, as you see in this picture. The same year, Professor Brennermark, in the same town, in the same university, maybe in another floor, was exposing his revolution in dentistry, the new dental implant with lot and more than 25 years of experience and research. It will be a revolution for the quality of life of millions of patients. It was the first revolution. 84. A new virus, the HIV virus, which brings us the new disease, mysterious disease, the AIDS, acquired immunologic deficiency syndrome, in which millions of people will be affected by this. The same year, we saw the polytetrafluoroethylene membrane, which is going to be a part of the routine of several periodontists, in which we were able to navigate the bone tissue healing by placing a membrane, but this membrane was non-resorbable, and we had to remove it after 2 weeks or until 6 weeks, with a lot of complication, but a lot of success too. It was the GTR, the guided tissue regeneration. It was in the 80s. 88. Madame Benazir Bhutto was the first woman elected to be a prime minister in Pakistan. It is a revolution in a Muslim country. But another revolution is going to be this year. I remember myself in a convention of French Society in Cannes this year. I was sitting in a whole conference, and on the podium, Mr. Dr. Professor Stuart Niemann comes on the podium and go up and speak about the ability of this polytetrafluoroethylene membrane to create bone and to make bone growing in jaws. It was a revolution. I look at my colleague on the right side, and he looked at me again, and we understood each other that everything is happening, and we understood that nothing will be the same in our professional life in the new year, in the next years. It was the beginning of the guided bone regeneration, in which, if we create a dead space with bone, without any interference of soft tissue, we can create bone. Only by placing a membrane. It was the fourth revolution. And you can see one of my first cases in the 80s, in which we were placing a membrane and having, after a few months, a creation of the bone. And placing a non-resorbable membrane is right now a routine for periodontists to build bone in a lateral way and in a vertical direction too. We can see on the left side the placement of a membrane, some bone to help and to give any basis for the bone formation. Fixing the membrane. And a passive closure of the tissue to protect the membrane. On the right side, the same surgery after 9 months, and we will be able to see how we can build bone just by GBR. Removing the pin. Releasing the non-resorbable membrane, and we can see the bone quality we have achieved. Very stable and very predictable bone. And we can see in this picture the bone formation and the good quality of the bone, and in width and in height. And we will be able to place dental implants in a good condition with a good prognosis. 89. The Berlin Wall is going to fall. And this year, I was in California, and I remember the wonderful article of Richard Lazara, one of the best clinician researchers we have in this field. And Richard made a revolution in which we can place a dental implant in a fresh extraction socket. And it was a revolution because now we had to wait to have a very good crest. And at those times, it was a little bit risky to place an implant in a fresh extraction. And he did it. And it was the fifth revolution. We had some cases, and I remember this case in 92 in my office. We removed lateral incisor in which we had a very, very big defect. It was an endoperioral defect. And we placed an implant at the same time, and we placed a non-resorbable membrane. It was a Gore-Tex membrane. At the same time, we placed the implant. And after a few months, we can see the healing. On the right side, the X-ray, on the left side, the clinical picture, with a very nice bone tissue reconstruction. It was in 92. But several problems with those membranes. We have to respect some criteria. Biological compatibility, cell selective activity, space maintenance, and stability. It was the problem in order to avoid any complication like perforation, exposure of the membrane, and infection. That was the problem of the non-resorbable membranes. 90. We have to wait the 90s to heard by the World Health Organization that homosexuality is not anymore a psychiatric disease. Don't you believe? This year, the collagen membrane, the resorbable membrane, came to the market. And it was good because we were able to place membrane and not to worry too much about any complication like infection, even though we had some exposure. The complication was very minor. And we have to thank Dr. Pitaru and Dr. Heimthal at those times to have developed this membrane. You can see on this small movie the ability to have some GBR technique with collagen membrane on the left side and on the right side. On the same way, we place the membrane, but we have to fix them in order to have no motion of the membrane and of the bone graft tissue. After several months, we can see on the left side the CT computerized tomography. On the right side, you can see the clinical picture. And in the middle, the movie. What are we going to achieve? A very nice building of the crest, in which we will be able to place an implant. This is the GBR by collagen membranes or resorbable membranes. It was the first evolution. 92. The Clinton family appears in the political life of the American people. This year, I was spending my time with Dr. Kalnish, and I would like to thank you. Dr. Kalnish has passed away a few months, and he was probably one of the best clinicians and researchers in the field of implantology. And I remember him telling me, Bernard, you have to remember, bone comes from bone. And he was right. We have done some cases with bone blocks, and I was influenced by the maxillofacial approach in which we had to do grafting by autograft. And we called It's the gold standard at the OCS. You can see in this moving and this clinical case, one of the cases we have done with a bone block in order to have any crest, any predictable crest to place an implant in the lower jaw. Some perforation to have any bleeding. We don't do anymore with the burr. We have the erbium YAG, and it's a very good instrument to do this way. And we took this wonderful piece of bone and we fix it on the crest to have a lateral augmentation. And we can see on this picture on the left side and the right side, the clinical and the computerized tomography, to show us the healing and the very good result we have done. We release the flap to place the implant, and we can appreciate the quality of bone in which we will be able to place a nice implant in good condition. Let's continue our trip. But we know, and we have seen during years, that nothing is so evident, nothing is obvious with the bone graft, because we have some obstacles, like bone resorption of the block. You can see in this case, we have done some bone resorption. So the results were not so predictable. That's the reason why we had to continue and to use membrane and some different materials. We are in '86, and this year we heard about Dolly, the sheep, world first clone mammal, and in Scotland, to be born in Scotland. It was a revolution too. But at this time, we have another evolution in our profession. This is the new consensus about bone particle like allograft on the left side and xenograft on the right side. We called it a platinum standard because we had so good results that we can use them on a routine way. You can see in this plate, in this case, the use of allograft as a routine. Always to protect the graft with a membrane. In this case, the double layer technique from Danny Boozer in close closure. It was the second evolution, with different progress like growth factors, like the BMP, and like the PDF, the PDGF. Those factors will add a lot of predictability to the bone grafting. It was the third evolution. Let's come back with our balloon to the new millennium, 2000. And this millennium brings us once again Jan Linde, but this time with a collaborator from Brazil, Dr. Arrojo. And they speak for the first time about the new bundle bone. And we hear about the new bundle bone, which is supposed to be the very thin bone after we remove a teeth. And this particular bone is very weak. is going to disappear after a few weeks. And we see the inability of any implant to keep the bone, and we call it the unavoidable bone resorption after an extraction. It brings us to understand that we need in all the case a socket preservation or a socket compensation, like they call it. It was the fourth evolution. 2006, the social network birth and a revolution for millions of people and millions of young people, in which this year we see Wang principle to appear, forcing the PASS principle, primary closure and passivity of the flap, perforation for angiogenesis to appeal and to receive blood supply, space to allow the bone growth, and stability by pin just to avoid any motion of the bone graft. And we understood that the protocol is very rigid. We call the rigor of the protocol, and that's the key for success. But many dentists have difficulty to keep this protocol, and that's the reason why sometimes the gibber is not so predictable. We are in the balloon very, very high, and maybe this is time for us to have any reevaluation. We are in 2007, and I was during a fly in connection between two planes, and I had the opportunity to find a friend of mine, Dr. Amos Yahal, and we were sitting in a coffee shop to have a drink, to have some coffee between two planes, and we had just 45 minutes. And Amos told me, Bernard, don't you believe that it's not time to think outside of the box? And I told me, what do you mean? Don't you believe is it not time to make things simple and to have any ultimate metrics? I didn't understand what he meant. And he began to speak about plaster of Paris, calcium sulfate, and the ability of calcium sulfate to be very strong and to be a good product, synthetic product for bone grafting. I was a little bit surprised because, we have just a few minutes to have a coffee, and I was thinking that I'm going to hear about a new product, and he speaks with me with the plaster, about the plaster. So, but he told me, Bernard, we have to change the crystallinity of the product. And he did it with a new product to avoid the obstacles. Those are the bone cement with the biphasic calcium sulfate, in which the hardening of a product is achieved in 20 seconds with the ability to disappear after a few weeks. This is a synthetic product, also conductive and bioresorbable. Those are the bone cement in dentistry. Very ergonomic product, very simple, place, press, and close. We adopt this product and we use it with the indication we need for this. Small defect, bone preservation after extraction. We can use as a membrane, because if you remember several years ago we had a membrane like this, and we were using this calcium sulfate to protect the bone. Some indication: socket preservation, free four-wall small bone defect, small lateral augmentation, or like a membrane for GBR or maybe for sinus closure. And we use this product as you can see in this case, with a socket preservation and an implant placement. Very simple. To press the product into the socket, to place it, to press, and in this case, after the implant placement, no closure, because we had enough bone to navigate the bone healing. Different case, small lateral augmentation like this. Or the case, to use it as a membrane for wide lateral augmentation, or to close the window of sinus. The sinus elevation has been done, and instead of using the membrane, we can place, press, and close the flap. That's a few limitations, and Amos knows about this. We need a longer space maintaining for bone graft, because we have seen that there is a fast resorption of the product and a short space maintaining ability for large defect. So the idea was to use composite grafts and to use any product which will be able to keep the volume of the graft. We speak about hydroxylapatite or bioactive glass. Those products were able and will be able to give any volume to the graft and to, I would say, to delay the bone grafting and to give time to the new bone formation to be done. Bone apatite with the mixing of the biphasic calcium sulfate and hydroxylapatite, and we tried it, and as you've seen, with wide bone defect on the left and on the right, the results. Or in minimal lateral augmentation, a mixing of bicalcium sulfate and hydroxylapatite with the bone apatite, or like you can see here, we have done two things. On one side, just bicalcium sulfate. On the other side, we have tried the bone apatite, mixing a composite graft. And we can see that the bone apatite gives more volume to the graft. On the right, you can see the results, the clinical results. We have done another case with a very deep and very severe bone resorption in the aesthetic zone, in which we had to remove 4 teeth. And we have done several stages in order to build the ridge. The first surgery, in which we had some good result on one side and less on the other side, we decided to have a new surgery, as you can see on the lower side on the right side, the second stage, in which we had a very nice building of the ridge in the lateral position, as well in the vertical position. And you can see the result after the second surgery with the bone graft, with the hydroxylapatite, and bicalcium sulfate, what we call the bone apatite. We have used a new composite of bicalcium sulfate and bioactive glass particles. Why bioactive glass particles? Several advantages to this product. First of all, this is an hydrophilic property. It has an hydrophilic property affinity with fluids. The second one, cohesiveness, bioactivity of the product, and also an osteostimulation of the tissue. So, in this way, the mixing of the bicalcium sulfate with the bioactive glass could improve our results. We tried, and I would like to show this nice case in which, in one side, we use just bicalcium phosphate, and on the left side, we use the composite graft. We had to remove teeth and to make what we call a socket preservation. On the right side, we have done a socket preservation just by using the bicalcium sulfate. And on the left side, we use the composite graft made of bicalcium sulfate and bioglass. You can see on the left side the composite graft during the socket preservation. And on the right side, the graft has been done just by bicalcium sulfate. Those are the results before doing the second surgery, in which we will have to do a sinus lift on the right and a sinus lift on the left. Those surgeries are supposed to help us to place implant. We took advantage of this sinus elevation to have some corals, to have some biopsy. And you can see on the left side, those are the results after we release the flap. Look at the nice ridge we have got after using the composite graft, mixing of bicalcium sulfate and bioglass. We are going to do the sinus lift. On the right side, a sinus lift. And before the implant placement, we take a core for biopsy. We achieve the sinus lifting, and on the right side, another sinus lift, in which we will take a core of the composite graft this time. Those core have been sent to the laboratory, and we have got the result. As you can see on the right side, we have 46% of vital bone which has been created. This is a very good percent. We have new bone formation, we have vascularized connective tissue, you can see, and we can see the new osteocyte on the right side. It was on the right side with the bicalcium sulfate only. And on the left side, what do we have? We have a little bit less. We have just 31% of bone formation, vital bone formation. But as you can see, we have new bone formation. You have osteocyte, but we see the residual scaffold. And my explanation, this is just my explanation, that the scaffold has taken the place of the vital bone. And we have to remember that a biopsy is punctual in the time. If we have done this biopsy in 1 year or 2 years, we probably could have more vital bone because of the resorption of the residual scaffold. Another case, very severe bone resorption after a periimplantitis. This young girl had to remove the implant, and we can see the very wide defect. On the left side, we can see the way we have done the GBR, the incision and the bone decontamination has been done with the erbium laser, in this case, to be sure that we have released all the soft tissue debris insertion into the socket. On the right side, we continue the surgery and we have used the composite graft made by bicalcium sulfate and bioglass. In this time, we had to build the buccal wall with the technique, the GBR technique of the sonic wall, with the resorbable membrane, the synthetic resorbable membrane. That's the surgery of the first stage. Composite graft with GBR technique. After a few months, we can see on the left the beginning, on the right the result we have done, and with surgery we'll show you clinically the crest we have achieved, we have got. I release the flap not only with the periodontal elevator, but by dissection, and you will see the incidence of my dissection. We took a core because we have wanted to know what kind of bone we had before the implant placement. That's the core which has been sent to the laboratory to have the results. And then the implant with another core in a vertical and cervical approach. Those core has been sent to the laboratory, and we will be able to see the results. On the right side, the cervical part of the bone, and you can see the very good result of bone, of the vital bone we had, 41. And on the right side, we're a little bit astonished because we just had around 20%. Why? If you remember, I will show you before we can come back to the surgery, and I would like to show you the way I release the flap. I left some connective fibers and some soft tissue on the crest. If you can see on this way, and probably those are the fibers that we can see in the result we have had right now, in which we just have 20%, probably because of the presence of the soft tissue at the apical part of the crest. So we are ending our trip, our balloon trip, and we are very close to have the landing. And I would like to have some conclusion with you. First of all, just remember that we cannot avoid the bone resorption after an extraction. But we need to think always on a socket compensation point of view to keep the width of the ridge. We can remember, it's very nice to remember that bone comes from bone. And we always are very pleased to have an autologous bone graft. But remember that bone substitute have a very good prognosis, a very good predictability in our profession. I'm of the generation that it will be very difficult for me to renounce to membranes. And I still remember the past rules of Wang, in which the rigor of the protocol is very important. But I would like you, dear colleagues and ladies and gentlemen, to remember that things change and we have to evaluate and think maybe bone cement in which the technology, engineers, and the new concept could help the dentist to make things easier and better. So we are learning, and I would like to thank you to have been a part of my trip today, and have a good day and have a good journey.